We're going to be talking about the management of rectal cancer, specifically T4 rectal cancers. So when we talk about cancers, the T staging, the tumor staging refers to kind of how big they are. And I'm sure Dr. Trinette is going to talk about that here in just a second. And so Dr. Trinette is the senior member of our group now. That basically means he can boss Shashi around when he gets back, so that's good. But he's going to talk about total neoadjuvant therapy for rectal cancer. Welcome, Dr. Trinette.
Thank you. Senior. All right. Well, welcome. Hope everybody got breakfast and enjoying the talks. Nice talks. Thanks for coming. The talk today, the topic was total neoadjuvant therapy. How do we get here? So it refers to rectal cancer, usually locally advanced rectal cancers. And it's a little bit of a historic talk and like, how did we get to where we're at now? So we'll review what we're doing now, so then we can go back maybe 100 years or more, and then see how it evolved from there. And as we go, if you have any questions on, this is for treatment, like Dr. Torgerson said, for mostly locally advanced rectal cancer and how we approach that nowadays. So going back to NCCN guidelines.
I'm sorry, I need to just double check something. Okay, I had to make sure that it was shared.
Oh, yes. Oh, good. Thank you. All right. So we'll review the NCCN guidelines, which for us, it's guidelines for treatment. They're algorithms that get updated a few times a year. They're super helpful. The treatment therapies by cancer type. Anybody can access it at NCCN, their website, and they're super helpful. So here, as far as rectal cancer treatment, we'll go through some of the things of what we do now for rectal cancer. If you have a rectal cancer that's stage 1, and we treat rectal cancers by stage, right? So stage 1, earliest of the stage 1s would be a T1 and 0 rectal cancer. These are the earliest of the rectal cancers. These are the ones that sometimes you can take out a polyp with a scope endoscopically or transanally with transanal excision using the robot. They're small enough, they're superficial enough that they don't tend to metastasize to lymph nodes when they have good prognostic features. So that's how we treat the earliest of the rectal cancers. It's minimally invasive. Patients sometimes go home right after the colonoscopy or the next day or the same day after they do transanal excisions with the robot. But like everything, not everything comes like in an early form, right? Then you have the middle of the road. You have the T1 to T2s and 0 rectal cancers that are still stage 1s, but perhaps T1s that have some high-risk features, or T2s that then start having a risk of lymph node metastases. And those then we treat with transabdominal resections, like with a robot. And that's when you see patients having low anterior resections with or without an ileostomy. They have this kind of disease. The same for stage 2s that are low risk, like higher rectal cancers like T3. Those we can go ahead and excise up front. But as we'll see for the guidelines, if you go down, these T3 that are M positive or T3 high risk with the lymph node positivities, these are locally advanced rectal cancers, and these can be stage 2s or 3s, and these tend to have higher risk of recurrence, higher risk of removing them with positive margins if you're not careful. So that's why the treatment for these involves shrinking them up front with chemoradiation when they're mismatch repair stable, and if they're mismatch repair high, like in Lynch syndrome, then nowadays they can get treated with immunotherapy. And they tend to have a good response, sometimes a complete clinical response. So what is this chemotherapy? So the talk is about total neoadjuvant therapy. So total neoadjuvant therapy refers to just chemo and radiation therapy. And nowadays, this total neoadjuvant therapy involves either long course chemo and radiation, or where you get chemo radiation for 5 weeks, and you can get that up front. You can either get long course or short course, and then do consolidation chemotherapy. And then if they don't have a complete response, they go to surgery, or they can do chemotherapy first and then chemoradiation. And at first, we did not know which was better, but we'll review some of the literature and see if there's any advantages doing chemoradiation first or chemotherapy first in these locally advanced rectal cancers when you're doing total neoadjuvant therapy. And that's what these strides. And basically, after you did all the treatment up front, if they melt away, then you can watch them and go into watch and wait. And some people will be able to avoid surgery, and we'll take a look at some of the studies and how we got there. And if they don't have a great response, then they still need to have surgery after they get all the chemo radiation. So again, what is total neoadjuvant therapy? So total refers to getting chemotherapy and radiation therapy instead of getting it after surgery like we used to have them do before, or wedge it or do chemo radiation, then surgery, then chemotherapy after. Total means you get all the treatment up front, and then depending on how you respond, you may need surgery after. And the neoadjuvant means that you get it up front before surgery, right? So you get chemo radiation before surgery, and that's total neoadjuvant therapy. Which one is better? Let's take a look at some of the issues here. So why use total neoadjuvant therapy? So the question is chemo and radiation tolerated better before or after surgery? And we'll take a look at some of that. After surgery, people are all weak, debilitated, and we don't tolerate chemo and radiation well after surgery a lot of the times in rectal cancer. Is there a downstaging effect if you get chemo radiation? We know there is. Does it increase complete clinical response and complete pathologic response? In other words, does it make the tumors melt away? Sometimes it does, and we'll see to what extent as we review some of the literature. And does it affect the ability to not have to have the rectum removed? You have a rectal cancer that just melts away with treatment, and then perhaps you don't have to have it removed, and then that may have some quality of life improvement issues because people don't need surgery. And we'll review how that happens and why. And are there any downsides to doing total neoadjuvant therapy? You know, you're doing more treatment. Is more treatment always better? No. Are we over treating some patients? Perhaps. So we'll look at the literature. So why do we need to get chemo and radiation for these locally advanced rectal cancers? Just picture the rectal cancer is wedged in the pelvis. Sometimes the rectal cancers have like tentacles, extensions that are coming outside. And it's not unusual for these locally advanced rectal cancers when you're trying to remove them to have positive margins if you're not careful and if you don't shrink them up front. And positive margins are a predictor of decreased survival and increased recurrence. So we try and minimize our positive circumferential margins at all costs. And those getting chemo radiation up front and shrinking the tumors before you have to perhaps remove them, does it decrease the chance that patients may need a permanent stoma? And we know that that is the case, so that's why we do, and we'll review why. But going back to 1908, Dr. Miles described the abdominal perineal resection, which was the treatment back then, one of the treatments that they had for rectal cancer. In 1908, anesthesia was very rudimentary. We did not have electrocautery. Obtaining hemostasis with big surgeries was a problem. And in his paper in 1908, he described, Dr. Cerny had first described the abdominal perineal resection for rectal cancer, where they went through the abdomen and through the perineum in 1884. So that's the first description of that abdominal perineal resection. Now the procedure is called the Miles procedure. But a lot of people before 1908 were doing perineal proctectomies. They were taking the rectal cancers out through the pelvis, through the bottom, through the rectum. But that did not address the lymph node spread that happens up towards the aorta or the inferior mesenteric artery. So until 1906, he looked at his series of 57 patients that he had done just resections from the bottom without going in the abdomen. And he found that between 6 months and 3 years, 54 of the 57 patients had taken out the rectal cancers had already recurred. So this is almost like a 90-some% recurrence rate within 3 years, which is not great. In 1908, he presented his series of 12 patients that had an abdominal perineal resection. And what he found was that the surgery it's a big surgery for not having great anesthesia or hemostasis issues, and that the mortality of this group was about 50%. So back then, the wounds were left open. When you cut the rectum out for the bottom, they stuck a bag in it with gauze, and then they would change it at the bedside every day. They did not have Dr. Dawson plastic surgery ability to close these wounds like we do now. So, I mean, things have come a long way, but let's just take a look at how things have evolved, okay? So almost 100 years later, to that Miles description where it was just surgery, no chemo, no radiation, there was a Swedish rectal cancer trial that actually looked at taking out the rectum, not necessarily with the surgery we do nowadays, which is a total mesorectal excision where we go wide around the rectum and do a nice mesorectal excision, total when the tumor is low or mid-rectum. But they added short course radiation therapy before the surgery. It's a big study. It was 1,100, almost 1,200 patients. And the median follow-up was 13 years. This is the long-term follow-up of that study. So at 13 years, overall survival, you know, a lot of these patients were in their 70s, 60s, 70s, and 80s. So the overall survival is 38% for the radiated group, 30% for the non-irradiated group, which is not a great survival, but this is overall survival. So you have the age factor here, right? But still, that was different. So it was better if you got short course radiation before surgery. And then the cancer-specific survival was 72% versus 62%. Which there's also a difference. And the local recurrence rate was lower when they got radiation first and then surgery at 9% versus 26%. And this is doing the surgery before the surgery was a total mesorectal excision. So our surgery now we think is technically a better surgery. So the question is, with a better surgery, do you need radiation still or not, right? But it's a kind of like a landmark study. And then after this, the Germans, they went ahead and they said, well, what about if we compare pre-op chemoradiation to post-op chemoradiation? Based on that study, we tried to do this study here in the US, but the feeling here was we felt so strong that pre-op chemoradiation was superior to post-op that we did not want our patients to go through, have to be randomized into getting post-op. So the accrual here in the country for that study, they had to close it because it did not accrue. In Germany, they were able to finish it. It started in 1994. It was a randomized controlled trial of locally advanced rectal cancers. And they compared pre-op chemoradiation to post-op. Main outcome was overall survival, which was not significantly different. But disease-free survival also was not significantly different. But when you look at local recurrence, the local recurrence was 6% when they got pre-op chemoradiation as opposed to 13% when they got it post-op. And that was significantly different. And then not only that, but when you look at the grade 3 to 4 toxicities, the significant toxicities from chemo and radiation, when you gave the chemo radiation up front before surgery, the toxicities were about 27%, whereas if they had to give it after surgery, it was 40%. So it was not tolerated as well. So from that, and then also you looked at the low rectal cancers that were included in the study, and the rate of sphincter preservation was higher when they got the tumor shrunken with pre-op chemoradiation. So less permanent stomas when the tumor shrinks ahead of time, and less local recurrence is what the bottom line is with that study. And kudos to them that they were able to finish that study because it showed in a randomized fashion that it's better to get the tumor shrunken before you take it out. And then in the other side of the world, in Brazil, the Haber-Gama group at the same time was working on, well, what if you get chemoradiation and some of these tumors may melt away, like squamous cell cancers of the anus, and perhaps people may not need surgery, right? That was radical. Nobody thought that was a great idea back then, but they did a study. They had 265 patients, and they looked at neoadjuvant chemoradiation, long course, and these were locally advanced rectal cancers, and they get neoadjuvant chemoradiation, and then they had two groups. They had a group that had an incomplete response to the chemoradiation. In other words, they still thought there was some tumor left in there, and they proceeded to surgery. And then they had a group that had a complete clinical response. They couldn't feel any tumor left, and those were watched. So then what they did is the people that had surgery and had a complete pathologic response, in other words, they went on to surgery because they thought there was going to be cancer left in there. They couldn't be sure there wasn't. And then the pathology report came back, oh, guess what? No cancer left in there. They compared that group to the group that they were watching that had a complete clinical response. So they wanted to know if it was safe to watch these patients, even though it looks like there was nothing there. You can't be 100% sure. So they looked at a 5-year overall and disease-free survival. There were 88 and 83% for group A that had the incomplete response and had surgery versus 100% and 92% for the ones that were being watched. So they were like, you know what, it may be safe and even better to not do surgery on these patients, right? So their conclusions were that when patients have a complete pathologic response, in other words, they go to a stage 0 rectal cancer from being locally advanced, that there's excellent long-term results irrespective of whether you take it out or whether you don't. However, they said that surgical resection may not lead to an improved outcome. And of course, there's higher rates of stomas whenever you start doing surgery on these rectal cancer patients, and you have morbidity and low anterior syndrome and other issues that happen once you have surgery that you may be able to avoid if you preserve the organ. So that's it for the Brazilian group. That establishes the possibility that you can do watch and wait on rectal cancer patients. And then here in this country, we formed like a rectal cancer consortium in the US, and it was led by Julio Aguilar over at Sloan Kettering. And this was an NIH-funded study, and between 2004 and 2012, accrued about 259 patients. And we were looking and see if you don't only get chemoradiation up front, but you get chemoradiation up front, and then it's a sequential, it's a phase 2 trial where group 1, 2, 3, 4, group 1 went to surgery after chemoradiation 6 to 8 weeks. Group 2 got 2 cycles of the chemo that they would get after surgery up front, and then 4 cycles, and then 6 cycles. And those were the groups they were comparing. So between group 1 and group 4, there was about 18 or 17 weeks of difference to let the chemo radiation work more and keep shrinking the cancers. Well, you were not doing anything, but I said you were still getting the chemo that you would have gone after, you get before surgery. So what we found was that as you look at the complete pathologic response when the specimens were removed, because everybody went to surgery in this group if they were able to tolerate the surgery, is that the longer you waited, the complete pathologic response when the tumor was inspected by pathology, it went from 18% at 6 to 8 weeks of having no cancer left in the specimen to about 38%, so almost 40% of patients, if you wait long enough and start getting more chemo up front and let the radiation work before you have surgery, have a complete clinical pathologic response. So the conclusions were that mFOLFOX6 after chemoradiation before total mesorectal excision has a potential to increase the proportion of patients eligible for less invasive treatment strategies like watch and wait or local excisions in some cases. And this strategy then was tested in a further trial. And this is a further trial then is we looked at the possibility, this was called the Oprah study. So that was the next follow-up study that we were involved in. And this was a phase 2 organ preservation trial. It was for stage 2 and 3 rectal cancers, randomized to either get induction chemotherapy and radiation therapy, and then possibly surgery or watch and wait, or do chemoradiation first and then consolidation chemotherapy and then possibly surgery or watch and wait depending on how they respond. So we wanted to know, is it better to get chemoradiation first and then chemo before surgery, or chemo first and radiation and then surgery if you need it? There was no answer to this question at this time. So if you had a complete response after efficient treatment, you could go into watch and wait. If you did not have a complete response, if you had an incomplete response, you needed to go to surgery. Primary endpoint was disease-free survival. Secondary endpoint was TME-free survival. And it was 324 patients assigned to the 2 groups. Median follow-up was 5.1 years. And the 5-year disease-free survival were similar, 71 and 69%. So whether you get chemotherapy first or radiation first before surgery, didn't matter the order for disease-free survival. TME survival, however, the ability to TME-free survival means being able to keep your rectum in place without having to have the tumor-specific mesorectal excision. So it was 39% if you get induction chemotherapy first and then radiation therapy, whereas you were able to save your rectum in 54% of the times, and that was clinically significant. If you get chemoradiation first and then you're getting your chemotherapy and letting the radiation keep working over time. So basically, that was the bottom line on that study. And then long-term analysis is continued to show that long-term organ preservation was possible in half of the patients with rectal cancer treated with total neoadjuvant therapy in those patients that enter watch and wait. In most cases of a tumor regrowth occurs during the first 2 years. And we know that when you follow these patients, like 99% of them will recur within 3 years. So our follow-up, if you're going to go and watch and wait, is most intense for the first 3 years, and then it settles down and it goes less frequent for the next 2 to 3 years up until the 5-year mark, and then about yearly we follow them at least 10 years or more. So that's how we got to possibility of watch and wait and total neoadjuvant therapy, chemotherapy first, radiation first. It's all it's all different things that you have that we have available now that we can taper to the patient. So everybody can get treatment according to their disease and how they respond. So for the future, I mean, what's in the future? Well, we're looking at the possibility, instead of more treatment, what about less treatment? Are there some patients that we can kind of just identify that have good disease, better disease that can be treated with less and still do the same with less morbidity? So we're looking at that. What about following patients with tumor circulating DNA in the blood, so liquid biopsies, to see if you can follow these patients that are being monitored for watch and wait, that you can't be sure that they don't have cancer left in there because you haven't taken the specimen out. So can you monitor them with ctDNA? So we don't know the answer to these questions yet, but there's studies ongoing right now and that'll be interesting because at some point, perhaps we monitor these patients with ctDNA as well. What about using artificial intelligence? Studies are looking at AI for assessment of clinical. When we're looking at these patients to see if they've had a good response to chemoradiation, you have to do the digital rectal exam, endoscopic exam, MRI exams, and we'll see some of the MRIs coming up, which really give us great, the MRIs are like maps for us when we're doing surgery and you have to do surgery on a rectal cancer patient. It helps us to have like great radiology, doing great MRI studies that are basically give us disease specificity to the millimeter so we can know where we have to go and go around, do our TME. So AI that can help us put all this together to see which patients are really going to benefit the most from watch and wait or not. That would be interesting. And then we're watching, also finding that the longer we follow these patients, things tend to fall through the cracks. Sometimes you feel better after 3-4 years and you don't feel like doing the MRIs and this and that. And we're monitoring this now. Especially we're applying for accreditation for the Rectal Cancer Excellence Program through the Commission on Cancer. And we're looking very closely at our compliance of these rectal cancer patients over time, because we know that everything as you follow them longer and longer, like in any study, that the compliance rate goes down. And we want to make sure that these patients don't fall through the cracks as they're being monitored with their organs still in place. So in conclusion, total neoadjuvant therapy, it does allow better exposure to chemotherapy. There's no doubt. If you need to get the chemotherapy after surgery, 50% of our patients were not getting the chemotherapy. Whereas if you get the chemotherapy and the radiation therapy up front, they tolerate it better and get better exposure to it, which is important in stage 2 and 3 rectal cancers. TNT opens a possibility for watch and wait, as we saw in some of these studies where we didn't have that before. We had TNT. And TNT offers a 50% rate of long-term organ preservation on watch and wait. So people can actually save the rectum. And we're thinking that if you can save the rectum, that your quality of life perhaps is probably going to be better than if you have a rectal cancer resection. But if you need it, depending on the disease, you still, you have to deal with it. But if you don't, it gives you an opportunity for better quality of life. And we know that 99% of the recurrences occur over the first 3 years when you're doing watch and wait after TNT. So that's why we taper our surveillance to that. So, and that's about it. Thank you.
We do have one question online. Okay, what are your thoughts on the Prospect trial?
So Prospect trial is kind of looking at the possibility of de-escalation, right? So what we're thinking, especially, I mean, you look at not only the Prospect trial, but also the Mercury trial where they had high quality radiology looking at rectal cancers. And when you have high quality studies, then you might be able to then de-escalate your treatment. And perhaps disease like, for example, T3 disease that would be stage 2 that normally would be considered for chemoradiation up front, surgery, and then chemo or total neoadjuvant therapy, that for a T3 low risk disease, especially a higher T3 in the upper rectum, that you perhaps can go to surgery and not get chemo radiation at all, and avoid that morbidity. As far as the Prospect trial, if you have a tumor that's still somewhat advanced, but you want to maybe try and avoid radiation therapy, you can do chemotherapy, and then still, if you think you can still do a good total mesorectal excision with negative margins, then that would be appropriate. So the Prospect trial has just opened the door up for us. When you have a tumor that you think you can resect with negative margins, that you may be able to avoid radiation therapy, comes in handy when you do a resection and it comes back more advanced disease than you thought, but you still had a good total mesorectal excision with negative margins. That in that case, you may be able to avoid radiation therapy, but still give the patient chemotherapy and do just as well. So de-escalation, I think that's where that's important. That and the Mercury trial. Thanks. Yeah, so the question, yeah, that's a great question. So the question is, when you do treatment, say you do total neoadjuvant therapy, right? Patient has a locally advanced rectal cancer. They go, say you do chemoradiation first, then you do chemotherapy. The chemoradiation is 5 weeks of external beam radiation with 5FU type sensitizing chemo, low dose, so that the radiation works better to shrink the tumor. Then you go into like 8 cycles of FOLFOX. Standard, it could be other agents, but standard FOLFOX. And that could be a few months. And then after, then then you go into an intense follow-up. And it's almost like a different talk, but the follow-up on watch and wait, it involves, you do every 3 months, you need digital rectal exams, make sure you can't feel any masses. You do flexible endoscopies or proctoscopes every 3 months, and then alternating every 3 months. So in other words, every 6 months, you get an MRI for the first 2 years. So it's a very intense follow-up. And then after the first 2 years, you go to like a 6-month follow-up, and then MRIs every year, and then you do some CT scans in between. So yeah, it's very intense follow-up. There's cost involved. We looked at a cost-effectiveness analysis of with all these MRIs and CTs that patients are getting, the costs kind of pile up. How does that compare to having a big surgery up front? You still need CTs and the other stuff. So the cost-effectiveness analysis that Maria Widmar from Sloan Kettering just did a nice review of that. It was a nice cost-effectiveness analysis, and it's complicated, but there are some advantages to preserving the rectum from a cost standpoint when you look at it over quality of life. But it's a very intense follow-up. That's the bottom line. Okay. Thank you. Yep.
Okay, so lots of recent changes to kind of how we manage rectal cancer. And I think it would be fair to say that probably one of the main reasons that we've been able to make so much progress over the last 20 years or so in terms of treating rectal cancer is sort of the shift towards utilizing MRI on a regular basis. Dr. Turnett described the MRI as basically our map. And so it allows us to accurately stage the patients at their initial presentation, determine what their initial treatment needs to be, and then if they're going to have surgery, restage them and see what we need to do exactly from a surgical standpoint, if we need to involve Dr. Corder, who's going to talk, or if we need to involve Dr. Dawson, who's going to talk. We're lucky to have Dr. Welch, who joins us at our tumor conference and reviews all of these MRIs for us. And so he's going to talk a little bit about MR imaging of locally advanced rectal cancer. Welcome, Dr. Welch.
All right, thanks for having me. I'm Daniel Welch. I'm a radiologist. I subspecialize in abdominal and pelvic radiology. And I've been asked, as you heard, to talk about MRI imaging of locally advanced rectal cancer. So hope to accomplish understanding the role of rectal MRI and particularly the initial staging of rectal cancer, understand some common patterns of local spread of tumor. We'll take a little bit more time focusing on some locally advanced T3, T4 disease. Hopefully you can appreciate the capabilities as well as some of the limitations of rectal MRI, both in the initial staging as well as in follow-up, like we heard in treatment response, and then understand some important technical factors, hopefully without putting you to sleep, that make for a great rectal protocol MRI. First, we'll review some anatomy just to kind of know what we're looking at when we do look at some rectal MRI pictures. We'll summarize some of the key landmarks that help create that roadmap for the surgeons and help risk stratify patients prior to treatment, inform surgical planning. We'll review some cases of locally advanced tumors, and then we'll discuss some post-treatment rectal MRI scans used in follow-up, whether that's a watch and wait approach, downstaging a tumor after TNT, or post-resection tumor, and how those differences and what we look for as radiologists, how that differs from pre-treatment to post-treatment exams. First, just a broad overview. These are the structures that we're interested in when we're looking at a rectum, rectal anatomy on MR. The sigmoid colon, the rectum coming down here, is surrounded, as I'm sure you've heard of, by the mesorectum or the mesorectal fat, which then is surrounded by mesorectal fascia. And these are all important landmarks that we need to identify when we're looking at a rectal MRI to give our surgeons an idea of the stage of the tumor, but also how involved these structures are. And then lastly, we'll look a little bit closer at the anal canal here inferiorly with some both pelvic floor musculature as well as the internal and external sphincter musculature. Got some diagrams here correlating with some axial images through the pelvis here. First, we'll take a look at the rectal wall layers, which is important for the T staging of a tumor. The mucosa, submucosa, and muscularis propria are the layers that make up the rectal wall. And sometimes we can see them pretty well on rectal MRI. In particular, this black outer rim, that's the muscularis propria, is really important because that's what's going to define a T1 or T2 versus a T3 tumor, a more involved tumor. And we can also sometimes see these other mucosa and submucosal layers, although those are often closely opposed. Here, labeled with the asterisk, is the mesorectal fat. It's a circumferential structure about the rectum, particularly the low to mid rectum. And then surrounding that is this really thin black line, which you can see that I'm highlighting with my mouse here. You can see it gets particularly thin in some areas, can be tough to see, but that's the mesorectal fascia. And that's a layer of fascial tissue that surrounds the mesorectal fat, roughly estimates the expected resection plane in a surgical total mesorectal excision. The anterior peritoneal reflection is another critical landmark here. I'll kind of illustrate that with a diagram, but just here's what it looks like on the T2 imaging, and that's the lowest point of the peritoneal cavity. It's where that peritoneal lining comes in to touch the anterior aspect of the rectum. It's also an important divider of the intraperitoneal rectum superiorly from the extraperitoneal rectum inferiorly. And it has important implications for staging. A tumor, as we see, that involves the peritoneal reflection will be a higher stage than one that doesn't, even if it's kind of the same extent of extension beyond the wall. And as you move higher in the rectum, from the low to mid to high rectum, the amount of rectum that's encompassed or encased by the peritoneal reflection and the peritoneal cavity increases. So a low rectal tumor, not going to have much chance of involving the peritoneal cavity, whereas a high rectal tumor, especially an anterior one, if it's extending beyond the wall, could very well involve the peritoneal cavity. Important to have some understanding of when does the rectum become the sigmoid colon, vice versa. Where's the division there? Classically, it's just a simple distance from the anal verge. So the low rectum traditionally is defined as 0 to 5 centimeters, mid 5 to 10 centimeters, and high 10 to 15 centimeters from the anorectal junction, with the sigmoid takeoff or the sigmoid colon being beyond 15 centimeters. I think that's more of an endoscopic definition traditionally. Some of the radiology literature says it might be more helpful to define it relative to the peritoneal reflection. So just low below, high above, mid maybe straddling the peritoneal reflection. And then another important landmark that we focus on is where does that sigmoid colon, we call it the sigmoid takeoff, basically where does it sweep anteriorly away from the sacrum? This comes into play when we're trying to define as something a sigmoid colon cancer versus a high rectal tumor. It can be difficult, but we try to just give the surgeons as much information as possible, and hopefully they've gotten a view of it endoscopically as well to kind of synthesize that information and decide what they think. Here's just an actual MR imaging that illustrates that sigmoid takeoff here, coming anteriorly away from the sacrum, back here and back here. And here's an important landmark as well, which is the anorectal junction, basically where does the rectum meet the anal canal. And speaking on the anal canal, here's some important diagrammatic anal canal anatomy. So the pelvic floor musculature, the levator ani, the puborectal sling are essentially contiguous, at least radiologically, as you move inferiorly and make up the external anal sphincter. Similarly, the muscular wall or the muscularis propria layer of the rectum, as you move inferiorly, is radiologically contiguous with the internal anal sphincter in the anal canal below the anal rectal junction. In between that, you've got a hopefully nice intersphincteric fat plane, which can divide those structures. As we'll see here, it's not always easy to see. This is a coronal MR view here. The red is trying to highlight the intersphincteric space. The bright stuff on this image is fat. And as you can see, it's pretty hard to see the intersphincteric fat. In a normal rectum, these things are often kind of closely collapsed or opposed to each other. Thankfully, when there's a tumor, sometimes these things get distended, and we can at least try to evaluate the musculature itself, which should be this nice thin black signal you see here. But it's not always straightforward, and that can be a problem in kind of evaluating for intersphincteric fat involvement in a rectal MRI. So here, sorry, kind of getting cut off here, but got a diagram of different T staging, and I'll touch on each of these briefly. You can read up here, but what we're looking at when we're looking at a rectal tumor for initial T staging is essentially what parts of the rectal wall does it involve? Does it extend beyond the rectal wall? And then does it involve the mesorectum or the mesorectal fascia? That's first and foremost. So any T1 or T2 tumor is confined to the rectal wall involving these layers. A T3 tumor extends beyond the rectal wall into the mesorectal fat, and we'll see plenty of examples of that. It can be subcategorized based on how far it extends beyond the muscularis propria into the fat. If some tumor is abutting or coming close to the mesorectal fascia, that gets a designation of mesorectal fascia positive or mesorectal fascia involvement, and that's puts a patient at a higher risk, of course, and is important for our surgeons to know because that's roughly the plane of their total mesorectal excision and puts them at a higher risk of positive margins. And then a T4 tumor is anything extending beyond that into the peritoneal cavity, the peritoneal reflection, that's a T4A tumor, or anything else, any other pelvic organ other than, the peritoneum would be a T4B tumor. Here's an example of a normal rectum, and then here's a rectum with some submucosal edema. No tumor here, but this is just to illustrate that the rectal walls under normal circumstances these layers are not really well seen. We can usually see the muscularis propria pretty well as this thin black line around here, but the other layers are just kind of collapsed into this gray signal here. With submucosal edema, you can see we can see these layers pretty well, the mucosal layer, the brighter submucosal layer because of the edema and the muscularis propria layer. But suffice to say, generally speaking, MRI is not really reliable for distinguishing T1 versus T2 tumor. Here's an example of a T1, T2 tumor, a polypoid rectal tumor. And what we're really looking for here on MR is that muscularis propria layer around the tumor is intact. We like to see that be a nice thin black line all the way around the tumor, particularly along the base of the tumor, which is where it's most likely to extend beyond and involve the mesorectal fat. So here's a nice example of a T1 or T2 tumor with intact muscularis propria all the way around. Here's another example of a T1 or T2 tumor. You can see this is kind of a polypoid rectal tumor with a stalk. There is some wall thickening of the rectum, which is important to note, but the mesorectal the muscularis propria line does not look disrupted here despite the wall thickening. So that's what we're looking for to define a T1 or T2 tumor. Conversely, a T3 tumor is a tumor that extends beyond the muscularis propria and into the adjacent mesorectal fat. As we talked about, we can measure that to sort of risk stratify the patient, decide how at risk they are for more advanced disease. And then we really care about this mesorectal fascia involvement. So again, this is the mesorectal fascia here, which is the black line around the mesorectum here. Most will consider it involved if it's within 1 millimeter. So we're dealing with pretty small distances here. Whereas if it's within 1 to 2 millimeters, that's a little bit of an increased risk. We will generally report that out as MRF threatened. And if it's less than that, it would be an MRF negative tumor. Unfortunately, one of the pitfalls of MR is that you can have this desmoplastic reaction adjacent to tumors, including rectal tumors. And that can cause the muscularis propria to get kind of indistinct here. And there can even be some signal abnormality that's dark and mimics a rectal tumor outside of the mesorectal fascia into the mesorectum. Here's an example on the left of a T3 tumor. You can see there's kind of bulky signal abnormality extending beyond the rectal wall. That's this blob here. On the left, that black line is tough to see, right? It's a little hazy. And there's certainly something extending beyond the mesorectal wall, but conversely to this more mass-like signal abnormality over here, this looks a little more linear. So this could give you a hint that it's maybe desmoplasia versus actual tumor extending beyond the wall. But unfortunately, a lot of the times it's hard to say for sure. Some centers will use a T2 or possible early T3 category for reporting these in their rectal MR templates. Depending on the center you're practicing at, it might not matter too much in the absence of nodal metastatic disease, because if it's an early T3 tumor with no, mesorectal fascia threatening or involvement, maybe this all just comes out as a TME anyways. But it is important, I think, for radiologists to communicate and clinicians to understand that's just an unfortunate pitfall, is this desmoplastic reaction can mimic tumor. We'll try our best to identify it when we can. Another important thing, and this is probably the most important kind of technical parameter for rectal MRI to understand, is the concept of volume averaging. I won't bore anyone with physics here, but when we get a rectal MR slice, we're kind of averaging signal that we acquire in a space. And if you acquire that in a plane that's not quite down the barrel of the rectum, that can make things look closer to other structures than they are. It can make things look fuzzy when in reality they're not. I'll show an example of that here, but that's a common cause of upstaging a tumor. Maybe you call a T2 tumor T3 because the muscularis propria layer looks a little fuzzy, or maybe you call something, mesorectal fascia threatened when really there's actually quite a lot of space just because we don't get. So anyway, what's important to know is it's really important when you're getting a rectal MR to acquire these sequences down the barrel of the rectum at the level of the tumor. When you get a just standard pelvic MR, generally speaking, that's just going to be straight up axial cuts, meaning head to toe. That's the plane we acquire in. When we do a rectal MR, we tailor those sequences a little bit more towards the plane of the tumor. Here's an example, the red being just a straight up axial cut, meaning straight up head to toe, down the body, whereas the yellow, you can see we oblique the orientation of these planes a little bit. In the red here, you can see that looks pretty close to the prostate. Maybe there's a thin little fat plane preserved, but it looks pretty darn close. And in the yellow, you can see we just angled that just a few degrees, and we can see there's clearly a preserved fat plane here. You can imagine when we're dealing with, distances of 1 to 2 millimeters with the mesorectal fascia, that could have a big impact. So it is really important to get these acquired in the correct plane. A T4 tumor, again, like we talked about, involving the peritoneal reflection, peritoneum, or anything beyond the mesorectum. Generally speaking, that's for low rectal tumors. We'll talk about external anal sphincter involvement, pelvic floor musculature involvement of the adjacent vagina or urethra, prostate or seminal vesicles. For a high rectal tumor, that could be the peritoneal cavity, adjacent bowel loops, or the bladder, maybe the uterus, depending on the location of the tumor. Here's an example of a T4A tumor. So we're at least in the mid rectum here, just to orient everyone. Here's the bladder here. So we're a little higher than like a low rectal tumor. Here's the tumor here. It's an annular rectal tumor. We were looking for this T2 kind of gray blob that's not normal in the rectum here. And here, this I'll highlight with my mouse here, the mesorectal fascia coming around here. You can see here, it's kind of nice, black, thin. Here, it's thickened. There's signal abnormality that's similar to the tumor here. So this is a grossly involved and thickened mesorectal fascia, or excuse me, peritoneal reflection here. And you would have to correlate that with the sagittal imaging to know that you're at the level of the peritoneal reflection versus just a mesorectal fascia involvement in a lower rectal tumor. One possible pitfall that could lead to overstaging is, we see structures of butt all the time. This came up just this week in a case that was a high rectal tumor just like this, very close to the uterus. It was grossly extending beyond the mesorectal wall posteriorly, but the the muscularis propria anteriorly looked intact. And here's an example of a high tumor with a nice intact, thin black muscularis propria. So yes, it's in the intraperitoneal rectum. It's above the level of the reflection. It's close to the bladder, but without extending beyond the rectal wall, there's not much concern for T3 or T4, in this case, tumor. Here's another example, same place, obviously a bigger tumor. Here's a nice kind of example of muscularis propria intact up here, but you can see at the level of the tumor, now we lost it. We can maybe pick it back up with the reflection, peritoneal reflection kind of coming in here, but now there's T2 gray intermediate tumor signal here. So this would be a T4, at least T4A tumor, and it's even getting close to the bladder there, and would need to look at that a little bit closer as well. This is just quickly illustrating that point that, a tumor that's anterior here in the low rectum, you can see it's kind of maybe threatening. This is probably abutting the mesorectal fascia here at this level, a tumor at this level, for example, which is highlighted in green here. So that's a T3 mesorectal fascia positive tumor. Here, similar story. It's an anterior rectal tumor that's invaded beyond the wall anteriorly, but it's above the level of the reflection. And so that puts that person in the T4 category with peritoneal involvement of the tumor here. Here's an example of a T4B tumor. So this is an anterior low rectal tumor. It's kind of semi-annular. You can maybe appreciate that there's tumor that goes from about here to about here with a relatively thin posterior rectal wall here. And you can see this is not only invading beyond the rectal wall, but this is the prostate gland here, and it's grossly involving and invading the prostate gland, compatible with a T4B tumor here. Here's another example of a semi-annular rectal tumor. I'm going to advance the slides moving superiorly to inferiorly. And here's the posterior wall of the vagina on the axial T2 imaging here. You can see here there's mostly a preserved fat plane, but as we move inferiorly, that kind of goes away. And now we've lost the posterior wall of the vagina, which was that thin black line here. And there's no fat plane. The borders are now indistinct. And this is an example of a T4B tumor involving the posterior vagina here. Another details for low rectal tumor specifically, that's additional factors we consider are basically anal canal involvement. So low rectal tumors can extend into the anal canal. They can be confined even if they're kind of T1, T2, what we call them T1, T2 up here. They can involve the the internal anal sphincter in the anal canal. When it does, we try to report how low in the anal canal. Generally, we talk about thirds, so upper, middle, or lower third of the anal canal. Important for our surgeons to know. Also, the nodal drainage pathways change, particularly in the lower third of the rectum below the dentate line, and that's important for nodal staging, as we'll see later. Let's see if we can show an example here. So here's a low rectal tumor. You can see this gray signal and wall thickening here, extending inferiorly here. And you can see those walls, and even that bright, thin intersphincteric space looks relatively preserved. So no involvement of the intersphincteric space and no involvement of the external anal canal, although the internal anal sphincter is involved by tumor, as it's just contiguous with the wall of the rectum here. Here's a low rectal tumor. We'll kind of compare side to side just to show what we're looking for. So tough to see. This person's probably got some muscular atrophy or something, but it's a nice thin black pelvic floor musculature, which comes into the external anal floor, the external anal sphincter musculature here, shown by the green arrow. Here's the tumor. This is a coronal look, so we're just looking straight on, kind of AP at someone's body. And you can see as we come inferiorly over here, the white arrows show the tumor is extending beyond into the intersphincteric fat, which is basically gone over here, and into those muscles of the external anal sphincter as well over here, which are involved by tumor, have this, we call it intermediate T2 gray signal over here. Here's an example of a low rectal tumor extending beyond the muscularis propria, invading the external anal sphincter, as well as the pelvic floor musculature, in this case, the levator ani musculature. Again, you can see this nice black kind of muscularis propria here, but we start to lose it as we get here. And then here on the coronal view, you can see this levator ani musculature is abnormally thickened. So those are the things we're looking for to tell. And then, this would make it a T4 tumor as well. So those are the things that are important for staging, as well as for giving our surgeons a roadmap. I'll just talk briefly about lymph node metastases. I won't go into all the detail here, but it's divided up into local regional lymph nodes and distant or non-regional lymph nodes. As I mentioned, a low rectal tumor, the inguinal lymph nodes can be considered local regional, which is important for staging and treatment, but generally they're not. Generally, those are distant nodal metastases. We also pay special attention to the more lateral lymph nodes in the pelvis. What's shown here in yellow is typically what would come out in a total mesorectal excision. So lymph nodes in here, one, they're local regional lymph nodes, and two, they would be expected to come out surgically. We try to highlight these lymph nodes when we see them, the obturator and internal iliac lymph nodes, because they may not come out surgically. So it's really important that we let our surgeons know that they're there if they are abnormal, so that they're aware of them, make sure they're in the treatment field, make sure they're, that at least the surgeons are aware of them. I won't go into too much detail here about nodal staging. Just, I think the important take-home messages are, MR is unfortunately not that great at staging lymph nodes, and that applies to rectal cancer, prostate cancer, cancers in the abdomen and pelvis as well. But the Society of Abdominal Radiology, or the SAR, has tried to come up with some criteria to standardize, which is what's used in most places. And it accounts for both the size of the lymph node and the morphology. So if you have these features, irregular borders, heterogeneous signal, or rounded as opposed to the more typical reniform shape of a lymph node, that those are all factors that increase your suspicion, and you don't have to be quite as big as a lymph node to be considered suspicious if you carry any of those morphologic suspicious features. When we talk about restaging, it just becomes a size game, and those criteria are outlined here. Here's an example of an enlarged mesorectal lymph node. It's within the mesorectal fat, which is surrounding the rectum. Here's some superior rectal or inferior mesenteric lymph nodes here, which are well above the level of the peritoneal reflection, adjacent to the superior rectal vasculature here. You can see these are nice big chunky ones, pretty suspicious. And then here's those lateral lymph nodes I tried to highlight earlier. The star indicates the mesorectal fascia. So these are beyond the mesorectal fascia. This is an internal iliac lymph node. It would be really important to identify for the clinicians. I'll talk briefly about post-treatment response. We heard a lot about TNT therapy, watch and wait approaches, neoadjuvant therapy. Typically, almost always when we see these now, the tumor shrinks and becomes increasingly fibrotic after neoadjuvant therapy. Even the rectal wall can even just appear normalized in appearance sometimes, where we can't even see the tumor, having not known where it was on the initial staging MR. So how do we try to identify residual tumor if it's there? Well, on T2 imaging, which is kind of the workforce, I haven't talked too much about the different sequences, but that's all the images you've seen today. We're looking for that residual gray intermediate signal. And the diffusion weighted imaging is another really critical sequence that we obtain for all rectal MRs. That's probably the most sensitive for identifying any residual tumor. Here's an example, pre and post chemoradiation therapy. Here's the tumor here, indicated by the yellow arrows. And what we typically see is it shrinks, one, so it's small, it's black, which is fibrosis. So that fibrotic response is what we're looking for, that tells us there's been a treatment response here. And this would, we try to grade it as a partial response or a complete response, factoring in, do we see any residual T2 signal? Do we see any residual diffusion signal abnormality? And if not, if we just see fibrosis, then that would be a complete response. Here's an example showing the T2 weighted imaging as well as some diffusion signal abnormality, showing how diffusion signal can be more sensitive here. Here's both, two different tumors, two different treatment responses. You can see the fibrosis here. Here, the diffusion signal, it looks black, essentially. There's a little bit of increased signal here. But here you can see this focus of bright spot here. This would be compatible with diffusion restriction, suspicious for a small amount of residual viable tumor. Just illustrating those points there. There have been attempts to kind of standardize grading this. This is the criteria that the SAR recommends we look at, which is taken from their template from the disease focus panel, which I've pasted here. This is a proposed tumor regression grading feature here, which I have not really seen used clinically, but just to show you a couple examples of what things we're looking for. Essentially, again, it's the T2 signal and the diffusion restriction. Really important to get good quality diffusion signal, diffusion restriction images with the rectal MR. And that's all I have. Thank you.
We do have one question online for you. Their question is this imaging done before surgery is scheduled, since some can be removed via ESD?
It's done certainly before surgery for initial staging. I don't know about the scheduling aspect. I don't, but generally speaking, this would be done, as part of the initial staging workup. We do, as you heard earlier, some of these tumors are kind of found incidentally, endoscopically. They take a polyp out, they find invasive adenocarcinoma, and they will often get a rectal MRI, and we sometimes see nothing. We see the little biopsy changes or surgical changes, but we don't see any tumor. So I think the short answer is in most cases, yes, it is.
Okay, perfect. So that was a great talk and shows, how helpful MRI is to us in determining what we need to do and what treatments to offer, and especially for surgical planning. Usually for our locally advanced cancers, we'll have at least 2, sometimes 3 MRIs before surgery. So we review those carefully. If our MRIs show us that we have an adjacent organ outside of the rectum, so growing through that fat into something else that's involved, that's when we have to start talking about what's called a pelvic exenteration, where we have to remove multiple organs together. And so we're going to have a talk on that by Dr. Chris Corder. He's one of our urology colleagues at the Urology Center. So we're fortunate to have him here today to talk to us. Thank you.
All right. Well, thanks for having me. God, full disclosure, the anatomy part of this is going to fall short of what Dan gave you, but this is a good spot for this particular talk, because you've kind of had an idea of, what do we mean by T4 rectal cancers, pelvic malignancies. That's where pelvic exenteration is going to come in handy. You've looked at all the anatomy. We've talked about some of the history. I'll go over some of those points. As Zach said, I'm from the Urology Center. I see a lot of familiar faces. So one of the urologists there. A big part of my practice is andrology, sexual health. I'll just make a few comments kind of at the end about sexual health, particularly for men and things after these types of major operations for pelvic malignancies. No financial disclosures for me. So overview, we'll talk about the basics, history, a little bit of pelvic exoneration, The anatomy, indications, what things can go wrong, what are the complication rates of a big operation like this. We'll look a little bit at urinary diversion. So as you can imagine, we have to do something with the urine once we take out the urinary bladder. We'll talk about that. And then, like I said, I'll make a few comments on quality of life, sexual function. So as an overview, this is typically a multidisciplinary operation. Colorectal, myself or one of my colleagues, gynecology, plastic surgery for reconstruction. It usually involves a lot of hands to get this done in a really efficient manner because it really is a big operation. When we typically talk about pelvic exoneration, we're talking about complete exoneration. We're taking everything out of the pelvis, but you can split that into anterior and posterior components. We'll look at those. And these can be done for obviously colorectal malignancies, but also, it's common for us for urologic malignancies and then gynecologic problems, T4 prostate cancers, things of those nature. So we'll look at all that. So when you look at when you talk about pelvic exoneration, you're looking at two components there. This is a mid-sagittal section of the pelvis, separating that into anterior and posterior components. The posterior component is the colorectal component, and then the anterior is always the bladder, and then the uterus for the female. So this was an operation that was originally described kind of in the late 40s to 50s. It was primarily for gynecologic malignancies, particularly cervical cancer. Limited use in the 1950s. As you can imagine, like Carlos said, surgery at that time was fairly rudimentary. We didn't have really good cross-sectional imaging at that point. Transfusion protocols, post-operative care, all these things were limited. So it made, this was a very morbid operation in the 1950s, as you can imagine. As we moved into the 1960s, medical advances, and this could be a lot of things, I would say primarily imaging technology. So into the 70s and 80s, as MRI and CT scan became more prominent and readily available, outcomes slowly improved. And what you'll come to see is that the primary outcome or the primary indicator of a good outcome is local control of that disease. So if we have residual disease within the pelvis or certainly disseminated disease, these outcomes are going to be very limited. So the imaging really obviously helps today to stratify those patients who's going to do well with this operation and benefit from this. Interestingly, real quick aside, Carlos mentioned the cautery, and I thought, well, I don't know when cautery was actually invented. I just looked it up and I was sitting back there. So that was in the 1920s. This guy, William Bovey, invented cautery. He sold that company for $1, the patent for that device, for $1 for the benefit of mankind. Interesting. So why do we do this? So colorectal malignancy is obviously the most common, in this realm, gynecologic, urologic, and then there's a few non-malignant things that we would do this for. These are typically radiation type problems. So radiation-induced fistulas, the urinary bladder, very sensitive to radiation change. So you can have radiation cystitis. You can have colitis that's just refractory. So these would be non-cancerous indications for the operation, but those are not very common. Primary contraindication, kind of mentioned this. This is really failure to get a negative margin. So like we talked about with the imaging, very, very important to have that accurate roadmap so we know that we're doing the right thing here. So again, same slide, anterior and posterior components for pelvic exoneration. We'll just look, kind of briefly at how we separate those. So this would be considered the anterior exent. This is a female, obviously, urinary bladder, uterus, ovaries, and potentially preserving the rectum and sigmoid colon. Posterior components, so rectum and sigmoid, uterus in the female going to be removed. You're preserving the urinary bladder and plus or minus the prostate for the male in the posterior exent. Complete, so this is what we're normally talking about. We're taking everything out, all the organs. Historically, this has been done in an open fashion that would still kind of be described as the gold standard for this operation. It's just a big operation that you need really good exposure and for everybody to do their part. We do it robotic now, and those the robotic advances have made this possible. We can now actually do a urinary diversion robotically. It makes it very easy to operate down in the pelvis. So a common question that patients and family members would ask us is, well, what's the deal with the robotic approach, and what's the deal with robotics? Or it allows us a wrist. So essentially, everybody pretty much knows what laparoscopic surgery is. Small poke holes, and you're operating with laparoscopic instruments. Where robotics gives us the advantage is that we have a wrist, so we can sew. We can see deep into the pelvis. So once you get really low in the pelvis, below the urinary bladder, near the prostate, below the endopelvic fascia, it's a very tight, dark, deep space that you can only really appreciate, during an open operation. So the robotics allows us to really get down into a deep space and have a very small wrist to be able to operate. And that's just miniaturizing our movements that we would normally do in an open fashion. And so that's becoming more common. That will probably become the standard of care for this operation at some point. So just a kind of random picture of a big abdominal pelvic exent, for these big tumors. So this is typically that approach. Now we can do this robotically. So you're seeing some of the robotic staplers, that have become available over the last decade. And robotic instruments. So again, allowing miniaturized staplers, which we didn't have before, and then a wrist to be able to manipulate these instruments. So complications, this is a big operation with a fairly significant complication rate, probably in the 50 to 60% range. One of the largest series published in the Annals of Oncology, they used NISPUT data over about 10 years. To try to look at what their true complication rate is for this operation. And that included all indications for a pelvic exent, so urologic, colorectal, gynecologic. And they found, based on that data, about a 60% complication rate, which is pretty consistent with what we would see for other indications. So in the urologic literature, if we were just doing bladder and prostate or bladder and uterus, we would generally quote about a 50% complication rate. For family members, this is a scary statistic. Depending on how you look at that, I would say that conversation would typically be, this is a very high complication rate, 50 to 60%. These are not all big bad things. These might be return of bowel function, wound problems, seromas, these sort of small things that are certainly not going to end in a mortality, but keep people in the hospital, quality of life, slow healing, slow their recovery. High grade complication rate, about 15%. So these are going to be the big things that are going to be serious adverse problems, ICU, extended hospital stay, etc. Mortality rate, thankfully now is about 2%. We saw those rates historically every year have really come down as we've improved all measures of surgical care. It's just an illustration of that NISQUIP data. So they looked at about 2,300 people. Actually, in this series, the most common indication was urologic because it's a common indication, advanced T4 bladder cancer, prostate, locally advanced adenocarcinoma of the prostate, but colorectal shortly. Oh, sorry. Colorectal just behind us. So we touched on this before, the factors that would predict success. So we want to get everything out of the pelvis. So we really want an R0 resection. These are typically T4 tumors at the onset. So this is where we rely on that imaging to really accurately stage patients. Overall surgical health. So again, cardiopulmonary fitness, nutrition, very important here because these are big operations. So we want to try to get folks in the best shape they can before we set out on a big operation like this. So again, the primary consideration for a good outcome is getting everything out of the pelvis. And so what we know is that if we see indicators on imaging or clinically that would suggest locally advanced into surrounding structures within the pelvis, such as the poor prognosis triad. So these are going to be invasion into the ureters that's going to cause hydronephrosis. Maybe these are big, bulky necrotic nodes, pedal edema suggesting compression of the iliac vessels, advanced nodal disease that's going to push on the iliacs, sciatic pain suggesting muscular involvement, nerve involvement. These are going to tend to predict a very poor prognosis. These are patients that we're probably not going to offer an operation to. Because of the extent of this, it's generally not offered as a palliative procedure, although that is done. Some of those fistulas, radiation type changes that have a very significant impact on quality of life, those would be reasons we would do this for a palliative intent. So if we remove the urinary bladder, we talk about urinary diversion. So this is a sort of a new thing for a lot of people when we talk about this. So there's two types of urinary diversions. We'll look at these. There's continent and incontinent diversions. So as the name implies, continent, these are going to hold the urine. You're not going to have any device or bag or catheter. Everything's going to be internal. Incontinent diversions, similar to a colostomy, we can make an ileostomy that drains urine. So you're going to have some kind of urine drainage bag or catheter. Simple goal, just to get the urine away from the bladder so we protect the kidney function over time. So these are the three basic diversions that you would see. The most common is going to be the first one there, the ileoconduit. So we're going to take about a 20 centimeter segment of ileum, not the distal ileum, but we work kind of backwards about 20 centimeters from the distal ileum and take that segment to use that as a conduit to get that urine to the skin surface. That's an incontinent diversion. So then on the other side, you have the continent diversion. So these are going to be storing the urine over a longer period of time with no device. So either the continent reservoir, also known as an Indiana pouch. This was developed in the 80s at the University of Indiana. The idea here is that you have a stoma that you pass a catheter in. So the urine is held in the pouch, which is made of ileum. You pass that catheter in, and then you drain the urine. There's a lot of maintenance involved with this, so this is not a common diversion that you'd see, especially in the colorectal world. These patients tend to be a little bit older. They have a lot of comorbid medical conditions. You know, I would tell you as a patient, there's a lot of maintenance and a lot of things that can go wrong with this that we may not necessarily want to take that extra risk, but that is available. Orthotopic neobladder, so we're creating a bladder or a pouch out of ileum. We're going to open up a bunch of ileum and we're going to basically recreate that into a sphere, and we're going to connect that to the urethra. And so now you're going to pee through your urethra, through the normal plumbing, and hold that urine almost normally. Again, a lot of issues that can come with that. These are generally not things that we're doing in the setting of a colorectal cancer resection, but it is available. More common, that would be for bladder, advanced prostate cancer, maybe in a younger, healthier population where they really want to avoid a stoma, etc. So again, the most common would be the ileoconduit urinary diversion. Crazy thing, this was actually originally developed in the late 1890s when they first described this. And it's just interesting to hear things from a surgical perspective that, you're in the late 1890s and somebody just said one day, let's try to take out a piece of your ileum. We'll attach your kidneys to the ileum, and then we'll bring the ileum out the skin surface and we'll drain your urine and we'll see if that works. And sure enough, it did. It was improved into the 50s and 60s. And that's the same operation that we do today, developed by Dr. Bricker. So that's just a picture of so again, just like any other ileostomy that you would see from the enteric side, this is just going to drain urine. Metabolic considerations are important here. So from a postoperative care standpoint, in long term, so that bowel is going to continue to act like bowel. So it's going to continue to absorb. So if you've got urine sitting in that conduit, there's metabolic considerations there. We'll talk about this. The longer the contact time, so if you're talking about a continent diversion where that urine sits, say in a Indiana pouch or a neobladder, the more metabolic risk we have. And that's, again, one of the considerations when we go forward with these is can we manage those safely over time? With an incontinent diversion, such as the ileoconduit, that contact time is much less, almost minimal. And so we see less metabolic issues with the incontinent diversion. but it's all about contact time. The most common metabolic syndrome, if you will, hyperchloremic, hypokalemic metabolic acidosis. We see it clinically, although it's rarely treated. Maybe 1 in 5 with a conduit especially would need bicarb supplementation over time. But if they have underlying renal insufficiency, diabetes, other metabolic issues, that can be a problem. There are times where we will not use ileum, we'll use colon, and that's going to change the metabolic derangements that you can see. I didn't get into that, but the longer the ileal segment can kind of change that. But generally speaking, we're not treating those over time. Just a few last minute thoughts on quality and sexual health. So this has been looked at. Quality of life functioning scores surprisingly are very, very good in patients that undergo big operations such as these. They do tend to report more physical, sexual, and social issues, and this is primarily around stoma, urinary diversion, and sexual function. So these patients are able to be sexually functioning, and that's absolutely a discussion that we try to have. Male versus female in the men's world. We have penile implants and things to help with erectile function. For females, vaginal reconstruction, reconstructing vaginal length, flaps and things that plastic surgery and gynecology can help us with to really allow for sexual function over time despite a big operation like this. That's all I had. Questions on that? Well, appreciate your time.
All right. Thank you very much. That was a great talk. And last, we will have Dr. Dawson talk to us. Dr. Dawson is one of our plastic surgery colleagues. And once we've kind of taken all this stuff out and made this big hole in the bottom of the pelvis, especially after radiation and everything else, we need some way to put it all back together. And so that's where Dr. Dawson comes in. All right. Welcome, Dr. Dawson.
Thank you guys for having me. I don't have anything to disclose, but all the photos in this presentation are not my photos. They're from articles. No one really wants photographs taken of their buttocks, especially like in a clinic setting, not like we do for mommy makeovers and things like that. So all these are from articles. I also would like to disclose that I think Dr. Sashi is cooler than me. So put that out there. And somebody's got to have his back. He's not here to defend himself. And then kudos to Dr. Person for stepping up and giving that GI presentation on the fly. That was pretty awesome. Okay, here we go. So why do these patients need to see a plastic surgeon? They come and they see me and they're really confused of why they have to have a plastic surgeon look at their buttock. They're not coming in for a BBL. This is a very different type of surgery. So when we do abdominal perineal resections, often, as we talked about before, these patients get neoadjuvant chemoradiation. And so the radiation is the reason why they're seeing me. If we resect the tumor and the distal part of the colon and the anus, then there's going to be a big defect that's left there. If we just suture that closed, it's going to be difficult for that to heal appropriately, high risk of complications, high risk of surgical site infection. So when radiation is involved, the blood vessels don't function normally. We can't really see it on a macroscopic level, but if you were to look at those blood vessels microscopically, you'd see that they look different than normal blood vessels. So that means bringing things in like oxygen, antibiotics, and just nutrients into the area are not going to be that great if we just leave that area alone and close it up primarily. Also, there's going to be a big hole there. So there's something called dead space. When dead space is available, our body wants to just put fluid into it. So then we get things like seroma, higher incidence for infection, higher incidence for potential hematoma because we don't have anything putting pressure on that region as well. So other reasons why they need to come see me too is just depending on the resection amount. Some APRs require posterior wall vaginectomy if there's invasion into the back wall of the vagina. And most women want that reconstructed so they can have sexual function. A third reason why patients are coming to see me is because they might not have a cancer, but they could have, pretty aggressive Crohn's disease, or they could have fistulas, for which their last resort is to have a proctocolectomy, and then in which case there could be significant soft tissue loss of the perianal area that will need to have a flap coverage. So, bottom line, no pun intended, what we want to do is we want to prevent wound healing problems. We want to reconstruct the normal anatomy. And lastly, we want to prevent a pelvic floor hernia. So there's really traditional options for reconstruction. There's kind of two big workhorses that we utilize and that all plastic surgery residents learn. And we'll talk about both of them and why we use them and why we don't use them. So the first one, and I think the one that is most commonly used, is gracilis muscle flaps. So we have some redundant musculature in our thighs that we can actually sacrifice the utilization of this muscle to help fill the dead space after an APR, and we can still walk normally. The trade-off is, though, that you have large scars on your thigh, and then it's a secondary surgical site that we have to utilize. But what do muscle flaps do? They bring in nice, healthy, vascularized tissue to an area. They can better deliver antibiotics, they can better deliver oxygen, and they can help revascularize the area where radiation has really affected it in terms of its blood supply. So why is the gracilis muscle really not a great option? A lot of it depends on the patient's body habitus. The gracilis muscle is never as big as the diagrams in textbook makes you believe. Once you start doing these surgeries, you realize that some people's diameter of the gracilis muscle is pretty darn tiny, just depending on how active they are. A lot of times our cancer patients aren't that active because they're going through chemotherapy and radiation. So they've got atrophy of the muscle. You think you might have a healthy, bulky muscle, and then you get in there and it's kind of piddly. It doesn't really have much bulk to it. So the bulk is an issue. There is a consistent vascular blood supply to the muscle itself that we have to keep intact during the surgery and that we actually come across during it. But the problem is that becomes a vascular leash. I cannot allow that muscle to be freed up more than where that vascular leash is. And so sometimes then I don't get the stretch that I want or the reach that I need for this type of repair. Other considerations, we talked about large scars on the leg, secondary donor site. And some people take a skin paddle with the gracilis muscle, but this is highly unreliable. So you can oftentimes you might think that this is a great idea, and then you start insetting the flap and you notice that the skin's turning purple because of problems with venous outflow, or it's completely pale because there's no arterial inflow going into it. So you can get lucky, and then you can get very unlucky with a gracilis skin paddle. So the other type of traditional reconstruction that we utilize is utilizing the rectus muscle from the abdomen. This is kind of what traditionally people used for decades, especially in the 1990s. It was very popular back then to utilize this, where we take one of the rectus muscles and then a skin paddle associated with it. We pre-plan this out with colorectal surgery and urology because stoma issue is, a consideration. I can't take this muscle and then have a stoma go right in that area. So we'll have to plan accordingly which side we're going to take. But what does this allow? This allows a great amount of bulk to be put down into the perineum to really plug up that dead space. And the skin paddle is super reliable. So it has those things going for it. Also, it gives us a lot of good skin to work with so we can reconstruct the posterior wall of the vagina very easily and also resurface the perineum at the same time with the same flap. And when we're doing big open cases, like when we're removing all the contents of the pelvis, you're right there. It's already open. You can swing this thing intra-abdominally and then bring it out through the perineum. And then you have your colleagues that are there to help you close up the abdomen as well. But why do I not like doing this flap? Because it has a huge donor site morbidity. You are taking one of the rectus muscles and you are essentially debilitating that abdomen and really increasing the risk for hernias after the surgery, or at least bulges into that area. That can be really difficult to reconstruct and really annoying for the patient. And to do this type of reconstruction, it kind of predicates the fact that you're doing an open approach. All right, so why do I no longer do these flaps? I really don't like both of them for different reasons. I found something that works better in my hands. It has less morbidity and it kind of increased my overall operative time. Changing methods of doing abdominal or of doing APRs. Dr. Person has come to me and he wants to do a lot of these robotically because it's better for the patient in terms of the recovery. So if we're not going to be doing a big open procedure, the VRAM is not my workhorse flap that I'm going to utilize anymore. And personally, I just don't like the gracilis flap dissection, working in between the legs, having these big long scars, this vascular pedicle leash, and the lack of bulk for inset. It just bothers me from a technique standpoint and then an outcome standpoint. I just don't feel like it's giving us really what we want. So what do I use instead? I have two types of reconstruction that I do quite frequently, depending on the nature of the APR that we're doing. So the first one is bilateral gluteal fasciocutaneous V to Y flaps, and we'll go over those. And then I don't really have a great name for this type of flap closure, but I just call it the three flap closure for APR when we do a posterior wall vaginectomy. So I mentioned before that one of our goals for reconstruction is to prevent perineal herniation. So if we go in and we don't reconstruct this area properly, there's always a possibility that the contents of the abdomen want to move through that area where the rectum and anus used to be, and then they can cause something called a perineal hernia, which can be really challenging to reconstruct. It looks like this patient here in the photograph did have some type of flap closure, but still had a recurrence. Still had this happen to them, not a recurrence per se. So what do I do to prevent this from happening? I actually, the first portion of all of my procedures, I'm putting in a piece of mesh. So I put in Stratus, which is a biologic mesh, and I'm basically kind of spanning it from the coccyx area over to some of the mesorectal fascia if it's available. Sometimes I connect it to the anterior cuff where the cervix used to be on the vagina, just wherever I can get some type of structurally supportive tissue that I can suture into. I'm trying to bridge this gap so that we don't get this problem. So this is kind of my insurance policy to help prevent it, as well as stuffing soft tissue in the area. All right, so gluteal V to Y. Some of these pictures are kind of graphic, but they will show you exactly what happens. I will walk into the operating room and I don't normally see a hole this large, but I do see quite a large hole to the point where you could stick your whole hand in through the defect and into the peritoneal cavity. So these holes are not small and they're actually quite deep. So this type of reconstruction I use when everything else is intact and it's just a straight standard APR, like the posterior of the wall of the vagina is there. What I like about gluteal V to Y flaps is that they're fasciocutaneous. So I'm not sacrificing any muscle. The patient can still ambulate normally. There's not an issue with looking out for a vascular pedicle per se. So these are very quick for me to dissect. And they have got a really reliable blood supply. So just depending on the size of the defect, sometimes I take one side of the buttock and sometimes I take both. And what I'm going to do with this is dissect all the way down through the fat to the fascia of the gluteus maximus muscle. And then I'm elevating this flap off of the gluteus maximus muscle medially. And then I'm de-epithelializing the medial edge of the skin in this area to kind of dunk inside the pelvic cavity and kind of really close that dead space. I do this dissection prone. So everybody always asks, can we flip a patient right after they do an APR and have a fresh stoma? Can we flip them prone? And the answer is yes, as long as you pad the stoma and you do it, in a relatively quick time frame. I haven't found issues with the stoma getting edematous or having significant problems with like necrosis. So here's an example of a patient who had just one side done, and it shows you the extent of the de-epithelialization. So all of this tissue here that's been de-epithelialized is going to be dunked into that cavity. And then here's imaging post-op where you can see a patient who had it done on both sides. So you kind of see this blackened area here where that's the area that has been de-epithelialized and kind of dunked and invaginated into that cavity to obliterate the dead space and then fill it with vascularized tissue. All right. So then we have my other workhorse, which is, I call it the three flap closure. So this type of closure we do when a woman has had a posterior wall vaginectomy due to an invasive cancer. And it can go both ways. It can be from cervical cancer that invaded to the rectum or rectal cancer that invaded into the posterior wall of the vagina. Either or is the same reconstruction. So my goal for this is I need to recreate the posterior wall of the vagina. I need to fill the dead space from where the APR occurred. And then I need to close the perineum up. So there's this really fancy three flap system that I like to use where we're utilizing tissue from the buttock to flip and invaginate and create the posterior wall of the vagina. So that's these markings here. So we're going to take a measurement from basically the length of the vaginal vault and then transpose that onto the buttock and then take the width and then transpose that to the buttock as well. Make an incision that's going down into the subcutaneous tissues and fat. And then still leaving perforating vessels coming through here from the fat. So it has a random pattern blood supply. After I do that, then I'm going to flip it and then I'm going to suture it and to kind of create then a neo or posterior wall of the vagina that actually has a pretty good caliber to it. Most of the time when I'm doing this, I'm trying to at least get 2 finger breadths in there. And then these women don't really have to do any dilation after this type of procedure to keep the vagina open. So here's an example from an article of the flap that is created to make the posterior wall of the vagina, and then inset. So we kind of turn it 180 degrees and flip it on itself. And then suture it very carefully. I think the hardest part of this is just making sure you're suturing the right components, because you don't want to keep skin in a plane where it's going to be buried in fat and you get cysts and sebaceous cysts and things like that that are hard to manage postoperatively. Okay, so once we have this portion of the procedure done, you can still see that there is a hole that was left by the APR that we need to cover. So the next portion of this procedure, what we're going to do is we are going to take part of the gluteus maximus muscle. I'm not taking the whole muscle. I'm only taking half of the muscle. This is the point in the procedure where I really curse Dr. Person for making me do this type of procedure because he did the surgery robotically. Because the sciatic nerve is right underneath the gluteus maximus muscle. And I'm a really low risk plastic surgeon, and this part of the procedure really, sometimes it's a little bit nerve wracking for me because I don't want to have anybody come out of the procedure with any issues being able to walk. But what I like about this portion of the procedure, though, is that the gluteus maximus muscle in most people is really bulky. It's one of the biggest muscles in our body. So I know I'm going to get a reliable amount of tissue here to stuff into that cavity and fill the dead space within the APR resection site. And then once I do that, I guess I didn't have another slide for this, I will lift up the rest of the skin and fat on the buttock as a fasciocutaneous flap. And you can see the back cuts here to do that. And then we rotate all of that tissue in to close up overlying our 2 flaps that we've just used. And then this is a 3rd flap. So essentially it's 2 adjacent tissue transfer flaps and then 1 muscle flap. So post-op protocol. So after I do this, there's a lot of surgery that has just happened to their buttock area. And it's really challenging for the patients to recover from any of these types of surgeries that we do. But from my perspective for the closure, I think it's a little bit more challenging than just closing things up primarily. So I always leave drains for all of these procedures. I want to wick away any fluid. I want to make sure that we don't get any fluid collections or infections. I always keep patients on antibiotics for at least 3 days postoperatively because my drains are communicating right to where that stratus mesh is located. I will have the patients be on full bed rest on postoperative day number 0, because usually by the time I'm coming in to do the surgery, I'm coming in like 4 o'clock in the evening and we're finishing up like 6 or 7 o'clock at night, just due to the nature of how these surgeries are scheduled. I don't really want patients getting up in the middle of the night without adequate physical therapy involved, because they cannot sit directly on their buttock. PT has to come help them get out of bed in like a roll to stand fashion. And then they have to favor sitting on the unaffected side from which we did surgery. And sometimes it's hard to do that. If I'm using both gluteus maximus V to Y flaps, then they have to really like offload on either hip and learn how to do that. And that's not something we're going to teach them at midnight. If I'm doing the 3 flap, I'm always going to take those flaps from the right side because I'm a right-handed surgeon. So it's just easier technically for me to do it on the right side. So then they have to favor sitting on their left hip. For females, the Foley catheter will usually stay in for 1 week postoperatively, because then we don't have to worry about them getting up to go use the restroom. For males, it's not really an issue. They can stand and urinate if they need to. For males in particular, after surgery is done, they get a little bit of a benefit for wound healing, because I can place an incisional wound vac on them, which really helps seal that incision line up and prevent infection. I can't do this for females because the posterior wall of the vagina and the vaginal opening is right in that area. I can't land a wound vac there. And then the biggest thing for my patients, I tell them, like, you are not going to like me for 6 weeks because you cannot sit down directly on your buttock like you guys are all sitting down right now. So they either have to be laying down, standing up, or then sitting on their hip, which is hard to do. And the reason for it is this: the human body takes 6 weeks to create a scar that's only 80% of normal tensile strength of skin. It's not even 100% at 6 weeks, but it takes that long. And in this patient population, it usually probably sometimes take a little bit longer because of their history of radiation. They're usually not as well nourished as most of our other patients are. But I just say for 6 weeks, if you can give me that time frame, I'd really appreciate it. All right, so how's it been going? Well, time will tell. I've recently started kind of these newer flaps over the past year. And it's not often that we get a lot of patients needing the 3-flap closure where we're doing posterior wall vaginectomies. So I've done 3 of these thus far. First 2 patients really had no significant complications. My second patient complained that she could kind of feel some of the scar tissue on the inside. It kind of felt like a rope-like sensation, but this has since dissipated. I just operated on a 3rd patient in December, so it's a little too soon to tell if she's going to have any issues. For right now, she has none that we're aware of. The V to Y, I tend to do this more frequently because we just see, I have a bigger patient population for that, males included. So I've done 7 of those in the past year, and really everybody's done quite well with it. The one patient that did have a postoperative fluid collection above the level of the stratus was a smoker, so I didn't know if that potentially had some effect. The other patients were non-smokers. So in terms of like preventing perineal hernias, I haven't seen any of those come back. Maybe time will tell with that as well. I haven't had any significant wound healing complications or return to the operating room for frank dehiscence, things like that. Okay, that's it, guys. Thank you for your attention.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.